Oh, thank you, thank you. So, welcome to this session of Target NEET-PG 2026, and today I have compiled few image-based questions from the previous few years of NEET-PG, and before I go into the session proper, there are few things which I want to tell you, like in especially with respect to anatomy. I think 70 to 80%. Good morning, Shamim. Really nice to see you here. Sunny, good morning, bache. So, especially with respect to anatomy of NEET PG, I think 70 to 80% questions are image based, right? That was like something which I noticed. And secondly, the image also are like not very straightforward. Most of the questions were like cadaveric image based or histological. So what we actually see in foreign medical graduate examination, the images are entirely different and obviously difficult also. So I have tried to compile good morning Kakul. So I have tried to compile few important images, and I'll just try to simplify the concepts rather than jumping on to the answer, and then we will take some related basic anatomical theoretical concept also, right? So with this we can start the session. Now the very first question was about like a cadaveric specimen, and here they have put two arrows, and then they have asked you about the nerve supplies of Osgood. I think app is available for iOS, but yeah, there is a different route, or else you can drop me a message on WhatsApp and I'll give you the link, right? So don't worry for that. Just drop me a message on WhatsApp. Okay, that's in the description box. Okay, fine. So the very first question is about cadaveric specimen. There were arrows which are pointing on to two muscles, and then the nerve supply was asked. Now usually when we give images or diagrams, then it is very easy to identify muscle, but in cadaveric specimens it needs a little bit of concentration to mark the answer, right? So it's little difficult in cadaveric specimens, but let us try our level best. So this is one muscle, okay, and this is the another muscle. So these are the two muscles, and if you look properly, it looks as if both the muscles are in continuity. So that is one clue here. So one muscle is going like this, and second muscle is going like this. So the one which is marked with the yellow arrow is anterior belly of digastric. Clear? So it is anterior belly of digastric, and the one which is marked in the black arrow, I think all of you can answer it now. It is the one which is going back, so it is posterior belly of digastric. Okay, so this one is the anterior belly of digastric, and this one is the posterior belly of digastric. Now these two muscles are very important, not only from this image point of view, even from their embryological concept point of view. Now just for the ease of simplification, I have tried to compile the cadaveric image and a diagrammatic representation of the same. So let us try to correlate the two. Now the one which is asked in the question was like this one, okay? So it was like this one. So this one is the anterior belly of digastric, like this, okay? So this one is the anterior belly of digastric, and then the another one which is going like this, this is the posterior belly of digastric, okay? So here we can see this one is the posterior belly of digastric. Clear? So anterior belly of digastric and posterior belly of digastric, and yes, in between the two you can see one more muscle which is coming like this, coming from the styloid process. This is stylohyoid muscle, right? So what we can see here, the anterior belly of digastric and the posterior belly of digastric, and in between the two you can see stylohyoid muscle. The nomenclature of stylohyoid is very easy. So stylohyoid, stylo word is from styloid process, and hyoid is obviously for the hyoid bone. Clear? So this is the, if you see here, this is the stylohyoid muscle, right? So this is how you can easily identify anterior belly of digastric and posterior belly of digastric, and usually they both scenes continuous like this. So anterior belly of digastric and posterior belly of digastric. Now coming to the nerve supply, although the nomenclature is digastric and some students think that the nerve will be same, but this is the catch here, the nerve is not the same for both the digastric. The posterior belly of digastric, it is supplied by facial nerve, right? And the anterior belly of digastric, it is supplied by the mylohyoid nerve. Clear? So this is mylohyoid nerve and posterior facial nerve. Now one thing I was telling you about embryological concept. Now anterior belly of digastric, it is derivative of first pharyngeal arch, and posterior belly of digastric, it is a derivative of second pharyngeal arch. Now these are some questions which are repeated again and again, so please be very good with this much concept and this will definitely help you, right? So anterior belly of digastric, posterior belly of digastric, and this also gives a little bit of freedom to discuss the triangles of the neck. Okay, so what we can do here, we can take, this is say the anterior belly of digastric, and say this is the posterior belly of digastric. Okay, this is we have discussed, and between the two, what we can see, this is the stylohyoid muscle coming from the styloid process. Okay, so anterior belly, posterior belly, and stylohyoid. Now in between these muscles we can see one triangular area, and this triangular area is the submandibular triangle. Clear? This is the submandibular triangle. So suppose if I give it nomenclature 1, so 1 is the submandibular triangle. As the name suggests, submandibular. Sub means below. So this is the lower margin of mandible. So this triangular area is submandibular triangle. Then see this big muscle. It is connecting the mastoid process to the sternum and through the clavicle. So this is sternocleidomastoid muscle. Okay, so this is sternocleidomastoid muscle. You can write it like this. So this is sternocleidomastoid. Anteriorly, we can see one muscle which is running like this. So this is the omohyoid muscle. It has got a superior belly, it has got an inferior belly. So superior belly of omohyoid here, then sternocleidomastoid, and posterior belly of digastric. Again it is converting this area into a triangular impression, and this triangle is the carotid triangle. Okay? So this is the carotid triangle. Right? Now if we go further behind, this is the trapezius muscle. Right? So I can write trapezius here, and lower down this bone is clavicle. So again it is forming a triangular area, and this triangle is known as the posterior triangle. Okay, so this is the posterior triangle. And again, if I write here, so this is posterior triangle. Yeah. Now in the posterior triangle we can see one muscle which is again divided into two parts. So one area is this, one area is this. So this is again divided by one muscle, and this is again inferior belly of omohyoid. And this divides into one, like if suppose if this is the inferior belly of omohyoid, the area above this is occipital triangle, and the area below this is supraclavicular triangle because it is above the clavicle. So supraclavicular triangle, right? So this is inferior belly of omohyoid, something like this. So anyway, this is just a basic recap of the triangles of the neck. The one which you can see in this particular image clearly is the submandibular, the carotid, the occipital, and the supraclavicular. Okay, so obviously these two are part of the posterior triangle of neck. So again, A and B. Clear? So this is in short about the importance of knowing digastric muscle. This not only helps you in understanding the triangles of the neck, also it has got embryological relevance that despite similar sounding, they are from different pharyngeal arches, and therefore they have different nerve supply, because we know that the nerve supply of the derivatives of first pharyngeal arch is through mandibular nerve. The derivative of second pharyngeal arch, they get nerve supply through facial nerve, right? So that's a very beautiful concept which you can understand from this particular image. So not going into unnecessary details. Anterior belly of digastric here, right? So this is anterior belly of digastric, and this is posterior belly of digastric. Between the two, stylohyoid muscle. Okay, so please remember this much. And the nerve supply: anterior belly, omohyoid nerve, and posterior belly, facial nerve. Okay, clear? So moving forward. Now, one histology based question. So what is being shown in the image? Now I do agree that histology is slightly difficult, but I'll try to simplify as much as possible. So now if you have this kind of image, now what you can see here, there is obviously we can see a lumen, something like this. So there is a lumen. Okay, so it means it is a tubular structure, number one. So what we can see, there is a lumen which is somewhat star shaped, or we call it stellate shaped. Clear? So the moment you have this kind of presentation where you see a transverse section of a structure in which we can see a lumen which is star or stellate shaped, think of ureter. Okay, so this is ureter. Now for the ease of understanding or correlation, I have taken the histological slide and I have taken a diagram to correlate the two. Now what we can see here, this label A is the lumen. Okay, so let us take the labels. A is lumen, and as I already told you, what is the shape of the lumen? Somewhat like a star. So this is characteristic star shaped or stellate shaped. The moment you have a picture something like this, that is ureter. Okay, now after the lumen, what we can see, the next label is the epithelium. So this is all epithelium, and I think most of you must be knowing what is the epithelium of ureter or urinary bladder or proximal urethra. So number B is the epithelium. An epithelium in ureter is transitional epithelium. Okay, also known as urothelium. So this is transitional epithelium. Now the label C is the inner longitudinal muscles. Okay, so these are the inner longitudinal muscles, and then after longitudinal there has to be circular muscles in ureter. So D is the outer circular muscle, and lastly is the fibrous coat. Okay. So what is important to see here? Number one, how you will identify the stellate shaped lumen. Okay. Number two, you can see these are the longitudinal smooth muscles, and I think all of you must be knowing what is the purpose of having smooth muscles here, because this is for peristalsis. The urine has to be pushed forward, so this is for peristalsis. So here inner longitudinal and outer circular. So this is very important to understand here, inner longitudinal and outer circular. Please remember this, inner longitudinal, outer circular. Now this is especially in proximal ureter. In lower ureter we can have an additional outer longitudinal layer as well, but let us leave it that for the timing. Okay, so inner longitudinal. Okay, so these are all longitudinal muscles, and these are all circular muscles. Clear? So this is the classical transverse section of ureter, very easy to identify. Please don't do any sort of error in this. And the only keyword which is going to help you, this star or stellate shape. So the moment you see this kind of lumen, think of ureter. Now there is one more important thing. Sometimes what they will do, they will give you a zoomed version of the epithelium. So it means you should also know what is this word, transitional epithelium or urothelium. Now here there are classical few words. See, whenever we discuss epithelium we say it is squamous, cuboidal, columnar, like that. But here you will have impression of either columnar or cuboidal, and you will also have impression of squamous variety. So that is very characteristic here. So if we take few words about transitional epithelium, which is also known as urothelium. Okay, so this is also known as urothelium because it is lining the urinary tract. Now this, I think, like whenever urine is coming, obviously the structure is distending. So this kind of epithelium, they have this feature of distensibility. Now coming to the classical histological features which you need to look into a given slide to answer this. Now what is happening here, there are few cells which looks like cuboidal or columnar, right? Few cells look like cuboidal or columnar. Then there are few cells which looks like squamous cells. So we have both kind of cells, either cuboidal or columnar. Now for columnar, I think this is columnar cell where the length or the height is more than the breadth. This is columnar, okay? And squamous, they can be something like this. So this is squamous cell. So here we have both kind of cells. In the base, in the basal area, we can see these are the columnar cells. Okay, so these are the columnar cells and having nuclei in each of the cells. So therefore there is no concept of pseudo stratification here. And then as we go upward, we will see polygonal cells which looks like the squamous cells. So these are two things, right? At the base we are having cuboidal or columnar cells, and as we go upward we can see the squamous cells. But there is a characteristic word which is to be used for urothelium, and that is umbrella shaped cells. Clear? So the moment you have this word umbrella shaped cells, think of urothelium or transitional epithelium. So the characteristic catch is characteristic word here is umbrella shaped cells. Okay, so again histology is little difficult, I do agree, but I've just tried to simplify some theoretical facts which you can apply to reach up to the answer, right? So this is transverse section of ureter, and the characteristic epithelium is transitional epithelium or urothelium. Now this is one more segment from which NEET-PG will give you questions. What they will do, they will put again most of the time they will take a skull and they will put a pointer in that, and then they will ask you which foramen is this, which structures are passing through these foramens, or some applied anatomy of those structures which are passing through that foramen. So here a marker has been pointed on some foramen, and then they have asked you like which of the following nerve do not pass through the foramen shown in the given image. So again you need to know which foramen is shown here, and then what are the cranial nerves which are passing through this particular foramen. So can anyone answer me which foramen is this? Any idea which foramen is this? This one? I think the easiest one which everyone can answer is foramen magnum. Magna means largest, so this is the foramen magnum, and if you see here, this one is the one which is asked here. Now this is jugular foramen. Okay, this is jugular foramen, and as the name suggests, jugular, so I think one structure all of you can remember, that it is the internal jugular vein which is passing through this, so that everyone can associate, internal jugular vein. So jugular, that's very easy to understand. Now the question is asking you about the cranial nerves, and here there are three cranial nerves which are passing through this. One is 9th, another is 10th, and the third one is 11th. Clear? So 9, 10, 11. So obviously if you go with the options, the answer will come out to be hypoglossal nerve, because it passes through hypoglossal canal. It has nothing to do with jugular foramen, so it passes through hypoglossal canal, right? Hypo means below, glossal is tongue, so hypoglossal canal. So this one is jugular foramen, right? Now for the ease of understanding, I have taken this image and with one more image which will help you in identifying the foramens. So this one is jugular foramen. Now anterior to this you can see one more foramen, and this is known as internal acoustic meatus. We have one external acoustic meatus, this one is internal acoustic meatus, and through the internal acoustic meatus there is passage of the 7th and 8th cranial nerve. So this one is internal acoustic meatus, right? Then this one obviously foramen magnum, and this is the hypoglossal canal which is giving way for the 12th nerve. So this is the hypoglossal canal. Then going forward, there are few important foramens which you should know, and the most important one is foramen ovale. I think all of you must be knowing that mnemonic of male for foramen ovale. Posterior to that, there is one very small foramen, and that is known as foramen spinosum. And this foramen is very small, but it is extremely important because it gives way for the middle meningeal artery. And we know that if there is traumatic rupture of middle meningeal artery, there is extradural hemorrhage. Okay, then this is foramen rotundum here, and this is the optic canal, which is giving way for the optic nerve and ophthalmic artery. This is cribriform plate of ethmoid bone, right, that forms a partition between the anterocranial fossa and the nasal cavity. Clear? So this is, now these foramens are extremely important. Please make sure that you know them very well. Okay, so this is how you can just correlate the foramens, and very important for you to remember. Now coming to the jugular foramen, as we already discussed that there are three nerves which are passing through this. One is the ninth nerve, glossopharyngeal. Okay, so this is glossopharyngeal. Again, the name is telling the territory, glossopharyngeal. Then vagus, the 10th nerve, and the accessory, that is the 11th nerve. So these are the three nerves which are passing through the jugular foramen. Now apart from this, as I already told you, the name itself is based on the vein, so that is internal jugular vein. So internal jugular vein, and the first tributary of the internal jugular vein is the inferior petrosal sinus. So this is how the structures are passing through the jugular foramen. Now it is not necessary to remember all structures of less importance, right? So remember inferior petrosal sinus, which is the first tributary of internal jugular vein, then 9, 10, 11, and obviously the internal jugular vein. So this is for jugular foramen. Okay. So next question. A football player has a twisting injury while fall and complains of pain at the knee joint. The examiner is performing which test? Now whenever there is any mention of twisting injury, right, so whenever there is any always think of some ligament injury. Clear? And the most common one which we see in clinical practice is anterior cruciate ligament. So this is the most common which we see in clinical practice, ACL. Okay, so this is ACL. Now look at the test, what the position is and what the examiner is trying to do, what maneuver he is trying to do. So look at the posture of the knee. Knee is flexed, and by what degree? It is somewhere around 15 degree. Clear? So the knee is flexed around 15 degree, and then okay, and then what is happening? By the right hand of the examiner, it is stabilizing thigh. Okay, it is stabilizing thigh, and by the left hand he is pulling the leg forward. Clear? What he is doing? He is pulling the leg forward. Now, so now what actually the examiner is trying to do? What he is trying to do? He is trying to check whether the leg can be pulled forward, whether the leg can be pulled forward, or instead of forward, I can write the word anterior. So he is checking whether the leg can be pulled anteriorly, or in simpler words we call it anterior translation of tibia over femur. Now, to make this concept even more simpler, what I'll do, I'll take a lateral view. So this is, say, lower end of femur, and say this is tibia, right? Now I am discussing laterally. Now there is one ligament. This will not allow the tibia to go anteriorly. There is one ligament which does not allow the tibia to go anteriorly over the femur, and this ligament is known as ACL. Right? This ligament is anterior cruciate ligament. So actually what the doctor is trying to do, he is trying to check the integrity of ACL. If the doctor can pull the leg forward easily, it means ACL is broken, because normally the ACL is not allowing the tibia to pull forward. Normally it will not allow. Only if it is torn, then the doctor can easily pull the leg forward, that is the tibia forward. So the doctor is trying here to check for the integrity of ACL. So this test is for ACL integrity. Now, when the knee is flexed to only 15 degree and we are checking the integrity of the ACL, this test is known as Leishman's test. Okay, so in Leishman's test, the knee is flexed to 15 degree. Now suppose if I am trying to do the same test, but I am flexing the knee to 90 degree, then the nomenclature of the test will change, and then it is known as the anterior drawer test. Clear? So what you need to remember, just look at the degree of bending of knee. 15 degree Leishman, 90 degree anterior drawer test. So in this particular image, since the degree of flexion is around only 15 degree, so we can say that this is clinical demonstration of Leishman's test, which is done for anterior cruciate ligament injury. Clear? So that's very important. So this is how you will solve this question. Now this is one very favorite question for exam setters, and it has been asked almost in every exam, FMG, NEET-PG, even NICT, and every time they will give you like pointers to some area, and then they will ask you, okay, what is the nerve which is supplying this particular part of the auricle. So if you see here, the auricle has been divided into 3 colored zones, one with orange color, another with green color, and the third with purple color. So it means there are 3 nerves which are defined, which are supplying different areas of the auricle. Now let us see what nerves are there. Now anyone can, so let me see if someone is willing to answer this. So orange colored, then the next is green colored, and the last one is purple colored. Yes, can anyone would like to answer this? Okay, now here let me give you some hint to solve the thing. Now there is one nerve which is supplying the temporal area and also the auricle. right? So temporal area, this is the temporal area, and this is the auricle. So what is the name of this nerve which is supplying temporal area and also the auricle? So it is very easy to answer. So this is auriculo, from auricle, and temporal from temporal. So this is auriculotemporal nerve. So AT, auriculotemporal nerve. So I think you will not forget this. So this area is supplied by auriculotemporal nerve. Fine. Auriculotemporal nerve. The word auricle is again external ear. So auriculo is external ear, and temporal is the area of the related to temporal bone. So this is auriculotemporal nerve. Very good, Kakul. Auriculotemporal nerve. Now purple colored. Now let us go on to the purple colored. This is great auricular nerve. Okay, so this is great auricular nerve. So this is great auricular nerve. Now what in the green area? This is auricular branch of vagus nerve. Right? So what is this green area? This is auricular branch of vagus nerve. Okay, so please remember this image. It is very important. I am telling you again and again, and in one or another way they will definitely ask. Now sometimes there is one more nerve which can be asked here, and this is the lesser occipital nerve. So if we write 4 here, this area is by lesser occipital nerve. Right? So although it is more onto the medial or the posterior aspect of the pinna, right? So it is not that dominant over the lateral aspect. So these are the 3 nerves: auriculotemporal nerve, auricular branch of vagus nerve, and great auricular nerve. Please remember this, and this is one image for your reference later on. So you can see this is auriculotemporal nerve, this is great auricular nerve, and this is auricular branch of vagus, and this is the one which is supplied by lesser occipital nerve. Okay, so this is the lesser occipital nerve. So please be perfect with this. It has been asked many number of times. Now another question: kind of field abnormality if there is injury at the location number 2 in the visual pathway. So now here you have to identify what is the location number 2 and what will happen if there is a injury to this area. So I think most of you must be knowing what is this area number 2. So this area number 2 is optic. Yes, anyone? What is this area number 2? Optic. Yes, I am waiting for some responses. Please don't feel bad if you mark it wrong. Just try. So this is actually optic chiasma. So what is this? Optic chiasma. Now the question is, very good, Kakul, this is optic chiasma. Now the question is, what is optic chiasma? So here what we can see, let us see this. Suppose this is the left eye and this is the right eye of the subject. Now what we can see, this is the nasal fibers and this is the temporal fibers. Similarly, this is the nasal fibers and this is the temporal fibers. Okay, so what is happening? The nasal fibers of the left eye are traveling like this, and then they are crossing on to the right side. Similarly, the nasal fibers of the right eye are traveling like this, and then they are crossing on to the other side and going to the left. So what is happening at the optic chiasma? There is crossing over of only, that's very important, only nasal fibers. So what is happening? Only the nasal fibers are crossing to other side. And now what is happening to the temporal fibers? Temporal fibers are continuing on the same side. Clear? So if I show you, this is the temporal fiber of left eye, it is continuing on the left side. This is the temporal fiber of the right eye, it is continuing on the right side. So the temporal fibers, they continue on the same side, whereas the nasal fibers, they cross over to other side. And the point of crossing is known as optic chiasma. Clear? So optic chiasma is the crossing of the nasal fibers of both the eye, where the right sided nasal fibers will go on to the right side and the left side, and the left sided nasal fibers will come to the right side. Clear? That is one thing. Now when we go to discuss the visual defect, now you have to understand that the visual impression is not like this, right? So it is not that the temporal field vision is taken by the temporal fibers or the nasal field vision is taken by the nasal fibers. It is not like that. It is actually like this in a crossed manner. So the nasal fibers, they are taking, so suppose if this is the temporal field, okay, and this is the nasal field. So the nasal field will go like this. So the image from the nasal field will be taken by the temporal fibers, and from the temporal field the image will be carried by the nasal fibers. So there is a crisscross, that is also very important. Okay, so there is a crisscross. So you need to remember three things. Number one, temporal field image formed on the nasal side of the retina, then the impression carried by the nasal fibers, and the nasal fibers will change their direction to right side. If they are going from the left side, they will change their direction to the right side, and the point of crossing over is known as optic chiasma. Now let us come to the question proper. With this anatomical basis, now let us come to the question in what the question is asking. So what if there is lesion at optic chiasma? So to answer this, you must know what fibers are there. So optic chiasma, we know what fibers are there. Nasal fibers, both eyes. Okay, so it means the nasal fibers will be gone. Now what nasal fiber is carrying with it? What sensation is traveling through the nasal fiber? It is temporal field vision, right? So it is carrying the sensations or the images from the temporal field. So both the nasal fibers are carrying images from both the temporal fields. So if both the nasal fibers are gone, it means there will be no image perceived in both the temporal fields. Clear? And therefore what we will call it? Bitemporal. Both side temporal gone, right? So bi means both, temporal is temporal field, then anopia is like no vision, and half of the visual field, so hemi and opia. Why we are calling hemi? Because it is only half. The other half is nasal. So suppose if I draw the visual field like this, so it has got two halves. This is the nasal half, this is the temporal half of field of vision, say for the left eye. This is for left eye. Clear? So what is happening here? There is no vision in this area. So half area is not showing any image. So therefore I am using the word hemi. Anopia means absence. An means absence, opia is vision. So there is bitemporal hemianopia. It means both side temporal field, no vision at all. So this is bitemporal hemianopia, and this is the commonest or the most favorite question for exam setters. And sometimes they might give you some clinical case question, and they will give you some pathology which is actually compressing upon the optic chiasma. So this optic chiasma is actually a very good Kakul temporal field both sides. So this optic chiasma is related to one gland. And what gland is that? Pituitary gland. Clear? So it is just lying above the pituitary gland. So whenever there is any tumor of the pituitary gland, it will injure the optic chiasma. Clear? So that's very favorite for exam setters. And for your reference, I have kept this image. So here we can see the label number 2 is optic chiasma. So I am skipping the other discussion for the time being, because that will take a lot of time. So this is what we have discussed till now. Like, this is the nasal field of vision here. This is the temporal field of vision. I'm just taking the left eye only, right? So nasal field of vision, the impression is created on the temporal fibers of the left eye, and from the temporal field of vision, the impression is created over the nasal half of the retina, and the image perception, the fibers they are responsible are the nasal ones, right? And then the nasal fibers will cross on to opposite sides. So this point is the optic chiasma, and when there is optic chiasma, there is bitemporal hemianopia. Okay, so bitemporal hemianopia, right? So we can see this is no vision here, no vision, and this is vision present. So only the nasal field the patient will be able to see from both the eyes. In both the eyes, the lateral field vision, that is a temporal field vision, will not be there. So that is a classical bitemporal hanopia, which will be seen with lesions of optic chiasma, because both sides nasal fibers will be damaged, and as the nasal fibers are carrying impulses from the temporal field of both the eyes, so there will be no vision in the temporal field of both the eyes. So very important from exam point of view, and I am skipping other types for the sake of avoiding any confusion. So for the time being, bitemporal hanopia, lesions of optic chiasma. Okay, moving forward to next question. What is being shown in the given image? Now here you can see there is some pouch or a diverticulum like this. So what is this? Now here I'll just give you one hint that this is mesentery. Clear? So suppose if this is the gut like this, and this is the attachment of mesentery. Okay, so this is mesentery. The diverticulum is on the other side, so it means the diverticulum is on anti-mesenteric border. Clear? So anti-mesenteric border. Now what do you mean by the word anti? Anti means opposite here. So it means the diverticulum is originating from the other border of the gut, which is exactly opposite to the attachment of mesentery. So this is one important clue, anti-mesenteric border, and this is the diverticulum arising from that area. Now another clue is that this diverticulum is having all the layers of the gut. So this is a true diverticulum, right? So it is a true diverticulum, as it is having all the layers of the gut. Clear? Now, can anyone answer this? I'll give you one more clue. It is a remnant of vitello-intestinal duct. It is a remnant of vitello-intestinal duct. I'll give you one more clue. It follows rule of 2. Yes, anyone? Very good, Kakul. This is Meckel's diverticulum. So rule of 2, like in 2% population, okay, then 2 feet proximal to ileocecal valve, 2 inch in length, right? Sometimes 2 types of ectopic mucosa. It can be, say, gastric, or sometimes it can be pancreatic. And since it is having gastric, so it can lead to bleeding sometimes. And this also helps us in by identifying this by radionuclide studies. So this is a very important topic, Meckel's diverticulum. You can read as much as in detail about this. So very important to read Meckel's diverticulum, and this is an incidental finding during some operative procedures. So this is Meckel's diverticulum. Now moving forward to one more foramen based question, and here the question was like, one of the nerves passing through the foramen number 2 is injured. Okay, so it is injured now. So what is the clinical presentation? So here what you need to do, you have to understand what is foramen number 2. Then second is, what are the structures which are passing through this foramen number 2. And thirdly, you need to know the applied. If there is injury to those structures, what will be the clinical manifestation? So let us go one by one. So firstly, we will identify what is foramen number 2 here. So what is foramen number 2? This one is the foramen number 2 which is asked in the question. Yes, anyone? This is foramen number 2. Now before that, let me help you a little bit more. Foramen 1 is optic canal. Okay, foramen 1 is optic canal, and foramen number 3 is foramen rotundum. So I have just simplified the things for you. 1 is optic canal and 3 is foramen rotundum. Okay, so 3 is foramen rotundum. Now, can anyone answer this? Opening number 2. Now, opening number 2 looks like a fissure. It looks like a fissure. Something like this. So this is some fissure, and the contents through this fissure, they are going to the orbit to have some supply for the eyeball. So the contents are going to the orbit. So what I'll write here? Orbital. Right? Now if we look at the orbit, this fissure is on the upper side. So I'll call it superior orbital fissure. Clear? So what is the name of this particular opening? This is superior orbital fissure. Okay. Now we have identified the foramen. Now we have to answer what are the structures passing through this foramen or superior orbital fissure? What are the structures which are passing through superior orbital fissure? Now it is very easy to remember. As I told you that the nerves, they are traveling through this foramen or the fissure, they are going into the orbit and they are supplying the extraocular muscles. Okay, so one point is nerves supplying extraocular muscles. Extra means outside, so extra is outside, ocular is obviously eye. So the muscles which are on the outside of the eyeball, they are supplied by the cranial nerves, and I think most of you must be knowing recti, oblique, all those are muscles, are extraocular muscles. So these extraocular muscles are supplied by three cranial nerves: cranial nerve 3, cranial nerve 4, and cranial nerve 6. Oculomotor, trochlear, abducens. And if you remember the very good calcul 3, 4, 6, if you remember the mnemonic SO4, LR6, rest by third. Okay, so one thing is that three cranial nerves which are supplying the extraocular muscles, they are traveling from the cranial cavity going to the orbit through the superior orbital fissure. This is one thing. But apart from this, there is one more important sensory nerve which is traveling through this fissure, and that is the ophthalmic, that is the branches of the ophthalmic division of, so branches of ophthalmic division of which cranial nerve? Ophthalmic division. One cranial nerve has three divisions: ophthalmic, maxillary, mandibular. Yes. Can you tell me which nerve is that? Which cranial nerve is that? So, ophthalmic division, maxillary division, and the third one is mandibular division. Very good, Kakul, very good. So, it is trigeminal nerve. Trigeminal nerve. The name itself is telling trigeminal. So one is ophthalmic, second is maxillary, and the third one is mandibular. But only the ophthalmic division branches are passing through superior orbital fissure. Okay, so the branches of the ophthalmic division of trigeminal nerve is passing through superior orbital fissure. Now these branches, they will supply the area of the scalp, the anterior part, the forehead, and the dorsum of the nose through the nasociliary, lacrimal, and frontal nerves. Clear? So what will now these are all sensory. Okay, these are all sensory. So it means if there is any injury to this particular division, there will be sensory loss. Now if we correlate all this theory with the options, option A, loss of sensation in the mucosa of nasopharynx, nothing to do. Loss of sensation in the maxillary area, this is by maxillary division, again not passing through the superior orbital fissure. Loss of sensation in the jaw area is mandibular, so again territory of mandibular division. So what we are left with now, loss of sensation on scalp and nose, this is provided by the ophthalmic division through its three branches, right? So only the ophthalmic division passes through superior orbital fissure. Again I am repeating, we write it 5 and 1. 5 Roman for trigeminal nerve, 1 means the first or the ophthalmic division. And again this is for your reference, like this one is the superior orbital fissure, and this is how you need to remember the contents. As I already told you, 3 cranial nerves. So the third nerve having 2 divisions, right? So third nerve having 2 divisions, the superior and the inferior, then fourth and the sixth. Clear? So third, fourth, sixth. Then what you can see here, you can see lacrimal nerve, you can see frontal nerve, and you can see nasociliary nerve. Now all 3 nerves, right? So if I write lacrimal, frontal and nasociliary, now all these, they are coming from 5-1, that is ophthalmic division of trigeminal nerve. Now these nerves, they are supplying this all area. So again you can see the dorsum of the nose, the forehead region, the scalp region. So this is by 5-1, ophthalmic division of the 5th nerve. And if you look here, this is the 5-1, which is passing through the superior orbital fissure, dividing into 3 branches, the frontal, nasociliary, and the lacrimal and the nasociliary branch. Okay, so this is what you need to remember. And this is passing through which foramen? The superior orbital fissure. So please remember this, superior orbital fissure. Okay, so this is very important because many times we have seen some question about superior orbital fissure syndrome, and then what is the presentation. So the only thing is, if you know the contents which are passing through the superior orbital fissure, it is very easy for you to answer this kind of question. So again, a very beautiful and very important question. So please remember this diagram, the 3 branches, lacrimal, frontal and nasociliary from the 5-1, and then 3 cranial nerves, 3rd, 4th and 6th. Right. So moving forward to next question. Now this is again very important and has been asked many number of times. Transverse section CT scan of chest. Right. So now this is CT scan. Now the first thing is, why you are saying that it is CT scan, why it is not an MRI? So to identify a CT scan, look at the bones. Firstly look at the bones, and if the bones are very bright or you say very white, it is CT scan, right? So the only clue which will tell you whether it is an MRI or a CT scan is look at the bones, and if the bones appear white, it is a CT scan. Now here look at the bones. Now which bones you can see? This is vertebral body, this is sternum, this is scapula, and these all are portions of the ribs. So you can see, and then at the back you can see the spine, the lamina. So vertebral body classically. So the moment you look at the bones, if they appear very white, you can say this is CT scan, right? Now this is a transverse section at the chest, and then they will ask you like what is this and this label. Now here the question is about label number G. Now before that, there is one more key rule which you should remember, because before answering this kind of question you have to say which one is anterior, which one is posterior, which is left and which is right. Now I think anterior and posterior will not be very problematic for you, because the moment you see the vertebral body, so this is the vertebral body here, right? So the moment you see the vertebral body, you can say that this is posterior. Clear? Vertebral body is posterior, and this is the sternum here. So this is anterior. So anterior posterior is easy to identify. Okay, so let me write it. Anterior, look for sternum, and for posterior, look for vertebral body or vertebra, right? This is one thing. Now the main catch is between right and left. So here what you need to remember, opposite of yours. It means your right side is left on CT scan. Clear? So your right side will be left and your left side will be right on CT scan. Is that clear? So just follow this rule, opposite to yours. So suppose if you are looking at this particular CT, this will become left and this will become right. Is that clear? This is the whole trick. If you remember this, you will never be wrong in your answer, right? So your right should be left and your left should be right on the CT scan transverse section. Now let us move forward to the labels. Now remember one more thing, blood, because it contains calcium, so it will also appear white on CT scan, right? So here blood will also appear white because it contains calcium. Then another question is, what is this black? Black here, black here, black here, black here. Now black means air. Okay, black means air. So obviously this is the air in lungs and this is air in the room. Clear? So black air, very good Kakul. Black air, white bone or anything related to blood which contains calcium, right? So now with this background knowledge we can take the structures. So now what we can see here, we can see some black areas, we can see some white areas. So obviously this is the lung field, air in the lungs, it is appearing black. Now apart from this you can see some more black areas. So again it means these are some structures which are having air. Okay, then we can see some white areas. So again white areas means they are some vascular structures. Okay, so these are some vascular structures. Now let us take the label one by one. So this is one black area, this is another black area. So these are actually the main bronchus, because right, suppose if this is the trachea like this, it will divide into two bronchus, isn't it? So it will divide into two bronchus. So this is say trachea, this is a right main bronchus and this is a left main bronchus. Okay, so now if we take a transverse section somewhere here, we can see the air filled spaces. So this is main bronchus, this is main bronchus. Now as I already told you, what you need to do, this is main bronchus, but on which side? Right side. This is main bronchus, but on which side? Left bronchus. So your label number A will be left main bronchus and label number F will come out to be right main bronchus. Okay, these are bronchus. Now posterior to the bronchus you can see one more black area. This is again containing air and this is actually esophagus. Clear? So D is what? Esophagus, and esophagus also contains air, so it will give you a black impression on CT scan. So right main bronchus, left main bronchus, esophagus. Clear? So we have done with the black impressions on the CT scan. Now let us go to the white impressions. Now what we can see here, something like this. right? So this is main pulmonary trunk, and main pulmonary trunk will divide into right pulmonary artery and left pulmonary artery. Clear? So this is the main pulmonary trunk, which has divided into the right pulmonary artery, left pulmonary artery. Anterior to this is ascending aorta, and posterior to this is descending aorta. Okay, so this is ascending aorta and this one is descending aorta, and this one is superior vena cava. Clear? So this one is superior vena cava. So this is how you need to identify the structures. Very easy and very important, has been asked many number of times. So here, if we go with the label, what is the label? A. A is left main bronchus. Clear? Left is, and this A is left main bronchus. Then let's go for B. Now what is B? B is descending aorta, right? So B is descending aorta. Now let us take the label C. C, I think, is very easy. This is vertebra. Okay, so C is vertebra. Then what is D? D is again black behind the bronchi, that is esophagus. So D is esophagus. Then what is E? Now if you see, this is landmark E, and E is present between the left main bronchus and the right main bronchus. So actually this is this area, the area where the where the trachea divides into two main bronchus, and that area is known as carina. Right? Carina is the area where the trachea divides into two primary bronchi. That is E. Then after that, F. This is F. So right main bronchus. So F will be right main bronchus. Then G, this is G, yes, towards the right side of ascending aorta. This is superior vena cava. So G is superior vena cava. Then H is ascending aorta. So this is ascending aorta. Okay, so H is ascending aorta, and I is obviously sternum. Clear? So this is how you need to solve this question, which is very easy to answer. Please remember this, and this is very favorite for exam setters. And again, this image has been given for your review later on from the PDFs. And then moving forward to one more histology based question integrated with clinical scenario. Here a neonate has presented with failure to pass meconium. Now in the histological slide, you have to show what area or what structure will be affected in this pathology of this condition. So here, firstly you need to identify that what is this condition, then only you can focus on the histology. So here the clinical presentation is a neonate, right, and failure to pass meconium. Now what is this meconium? Meconium is stool, right? So these are the stools of a newborn. So it means the newborn is not able to pass stools. It means there is no peristalsis, and this classical condition is Hirschsprung's disease. Clear? So this is indicative of which clinical condition? Hirschsprung's disease, right? Now this is also known as congenital aganglionic megacolon. Clear? So this is also known as congenital aganglionic megacolon. Now I think all of you must be knowing what is the meaning of congenital. Congenital means since birth. Aganglionic, A means absent, and what is absent? Ganglion. And as a result of this, there is dilatation of the colon. So mega means big, so there is dilatation of the colon. Now there is absence of ganglion, and therefore there is constriction of a segment of the colon. Now what ganglion are these? There are actually two. One is the myenteric plexus and another is the Auerbach's plexus. Clear? So these two plexes are absent in the colon, and therefore what will happen? So suppose if this is the area which is not having any ganglion, so it will be like this, and proximal to this the colon will dilate like this. So this is proximal dilation, and therefore it is known as megacolon, and this is the constricted area. And why it is constricted? Because there are no ganglions in it. So this is the classical pathology of Hirschsprung disease. Now this has been integrated with histology, and now in histology we need to identify that which label is actually representing the ganglion. Now here you can see CM, this is actually circular muscle. You can see LM, this is longitudinal muscle, and you can see N, which is actually the nerves or the Auerbach's plexus. So in a case of Hirschsprung disease, these will be absent. Clear? So Auerbach's plexus is absent. So this is what is being asked in this particular question. So again, if we look at the histology, we can see here this is the Auerbach plexus, which we can see, right? So this is the Auerbach plexus, which is present between the longitudinal and the circular muscle. So this is the circular muscle, this is the longitudinal muscle, and in between the two we can see the Auerbach's plexus. Okay, so this is longitudinal muscle here, these are the circular muscles, and in between the two we can see the Auerbach's plexus, right? So I do agree it's a little difficult question for a student to solve, but this is how you need to correlate the clinical presentation with the exact pathology, and then what is going to be the histological appearance of that condition, right? So for this presentation I just kept only 10 questions because I presume that it is going to be a time taking session. So but I am very sure you must have enjoyed the session. So very shortly I will come up with some more sessions, and yes, if you do have some your opinion, like what should be the content, I'll definitely prepare the questions according to that. So thanks for joining this particular session. See you shortly with some more sessions for NEET-PG 2026. God bless. Keep on studying. Bye bye.